Okay, welcome to the Integumentary review for the AANP exam. This is the exam that will help you to certify as a family nurse practitioner. I'm just going to go through high yield integumentary conditions, 9 of them to be exact. I expect that I'll have to do another one of these videos, but these are ones that the AANP loves to test on. First one is Rocky Mountain Spotted Fever. Now you're going to see here some spots that look like petechiae. Right here we have the feet, right here we have hands, again hands, and then here's the back. So what's going to happen with these patients is they're going to come in with viral symptoms. The viral symptoms are going to be kind of high fever, headache, muscle aches, and they might have a conjunctival infection. You're also going to see nausea and vomiting and also joint aches. This patient will then, what differentiates them is first the high fever, and then second the petechiae that starts on their hands and their feet. The petechiae will then spread to their back and their trunk. The Rocky Mountain Spotted Fever comes from tick bites, particularly dogs and being in the woods. Here we have a map of where the most common places to get Rocky Mountain Spotted Fever are. I live in Virginia, so this is particularly more useful to me. However, I would see how if maybe you lived in Maine, where there's a ton of trees, a ton of woods, but you don't have any Rocky Mountain Spotted Fever. This might not be particularly useful to you clinically, but the boards do love to test on this, so you do need to know that if you see somebody with Rocky Mountain Spotted Fever, first know this is an emergency. 3 to 9% of people with Rocky Mountain Spotted Fever do end up dying. So you want to be able to spot them. It's going to be the high fever, and then it's going to be the petechial rash that points it out to you. The petechial rash will spread quickly. That's another point. When you have this patient, you want to send them to the hospital emergency room immediately, where they will be started on doxycycline 500 twice a day for 21 days, generally. Next, we have a precancerous lesion, which is called Atopic Dermatitis. It's a slow-growing, dry, round, red-colored lesion on the skin that does not heal. It's usually in sun-exposed areas, so very commonly on elderly people on their head. You also have some truck drivers that get it on their arms. It's just something that's not healing, that is red, round, and slow growing. What you want to do with these is either send them to derm or do cryotherapy or both, especially with a small number of lesions. If you have a larger number of lesions, you definitely want to send them to derm. If these are not treated, it will turn into squamous cell carcinoma, something you really do not want. Next one is cirrhosis. So we have a couple really classic presentations of cirrhosis. First is on the back of the neck. That's a great first presentation. Another great first presentation is this back of the hands. That's going to be an earlier stage presentation. Back of the elbows, we can see looking at this that we have a lot of flaking, a lot of redness. That is because the epithelial cells are growing at a crazy rate. This is an inherited disorder in which people have, through the generations, epithelial cells growing very, very quickly. The epithelial cells have nowhere to go because they're just building on top of each other, which is why you're getting this dry, flaky, very tough, itchy rash. A key with this is that the patient's going to come in itchy. If you see this no itch, it's not psoriasis. Psoriasis is described on the exam as pruritic plaques of fine silvery scales found over elbows, scalp, knees, and gluteal folds. Consider when you see this that this is a chronic condition, so we don't want to jump really quickly into saying that this is going to heal quickly. Please warn the patient that it is going to come back. It's going to be a long road, and it is a chronic condition. We want to treat outbreaks of this kind of the same as we would eczema. In that, we're going to use a steroid and then just general good care of skin. That includes keeping the area dry, not taking really hot baths. That includes using good skin cream like Eucerin. We want to, when we're using, especially for the psoriasis patient, when we're prescribing steroids, we want to start with the lowest dose that we can, and we want to give very specific instructions to not slather yourself in a bath of betamethasone. That will cause a lot of harm to the patient, way worse than psoriasis ever was. So always want to be very safe when taking the AANP exam. If you can get away with hydrocortisone, that would be great. I don't think that you necessarily are, so betamethasone might be a good choice, and a low dose cream would be great, because consider the area that the patient's using. If they have psoriasis all over their body, you're going to be a little bit more worried about side effects than if it was just, say, just on that one. Next one, this is Tinea Versicolor, and it has a great name because it really is a rash that is lacking color. When you are documenting this, you want to write down that the rash was hypopigmented, meaning that there's a lack of color here. You can see that these are macules, and also that these macules are sitting on top of each other. They're invading each other's space. That's going to be a very classic presentation of Tinea Versicolor. Look at the name of this again, Tinea Versicolor. Tinea, meaning this is a fungal infection. It's going to have round macules on the chest, shoulder, and back after the skin is tanned. You could do a KOH slide and you would see spores that look like spaghetti on meatballs. For this, since it is a tinea, a fungal infection, we're going to treat it with an antifungal. You can choose a lot. There are a lot of different choices that would be good. I think people's first choice usually with this is going to be the fluconazole, whether you do, or the ketoconazole. Whether you do either one depends on really what you choose as a provider. But consider if you're going to do a cream or if you are going to do an oral. Either would really be acceptable. Topical is definitely going to be for a different type of patient than oral. If you do a ketoconazole oral, you want to do it twice a day for 2 weeks. Okay, you must know what this one is. I'm confident you do. This is atopic dermatitis. This is again an inherited itchy rash. So really close, really similar to psoriasis. However, this is going to be appearing in younger patients. Patients are going to come in before the age of 2 saying that they have this itchy, really thick rash. Eczema is a cyclic disease, meaning that we're starting out with something that's just itchy. The patient scratches it a lot. It looks a lot worse. This baby here right now is scratching it as we speak. We do not want that because if they scratch it, it becomes open and infected. So always on the lookout for infected eczema. As the infant gets older, so right here they have it on their face and their trunk. As they get older, it's going to be really in flexor areas. Flexor areas, if you see that on the exam, your antenna should go up. You are thinking about atopic dermatitis. It's a pruritic rash on your hands, flexor folds, and neck. It's exacerbated by stress and environment. It starts out as small vesicles that rupture, leaving red, weeping lesions that then become lysinified and itchy. So, how are we going to treat this? Same as psoriasis, kind of. So basically day to day for these patients, especially when they're children and it might be all over their body, we're going to want to use Eucerin, Aquaphor as their basic treatment. So go ahead and at the end of the day, take a bath that is warm, not hot, and then just slather yourself in Aquaphor. For those exacerbations that are just not going away, we're going to have to use a steroid. Triamcinolone is a favorite for eczema, but you can always go back to our list and consider what might be best for your patient. If you can get away with a hydrocortisone, get away with hydrocortisone. You don't need to go all the way to the higher level conditions. I mean, the higher level steroids. This next one, you probably know what this is because you see it a lot in the hospital as a registered nurse. This is acute cellulitis. Now, an infection of the skin. How can these happen? A lot of different ways. So we have stasis dermatitis, which causes cellulitis. That means the blood is not returning back to the heart adequately. We can have some type of open wound that then gets exacerbated. And then even in some people, we just have stuff under the skin that can cause it. Like a collection, like a folliculitis, for example, could cause a cellulitis. So that's an infection of the skin follicle. Well, I guess we really didn't call that folliculitis. But in any case, a lot of things can cause what we're seeing on the screen right now. What we want to consider is, because this is an infection just like any other, what is causing this cellulitis? In most cases with cellulitis, we're going to be thinking staph. If it's on the lower legs, like these two slides are, we're considering Mercer. The lower it is, the more highly likelihood that this is Mercer. So, how do you treat Mercer? A great way to treat this would be clindamycin. You're going to want to do clindamycin for at least 10 days. And if you're thinking it's maybe a lesser cellulitis, you might want to consider doxycycline, say if it was on the upper body. I've also seen some people choose amoxicillin or Augmentin for that. That would be fine too. You see right here, it looks like he's got an abscess. There's a smaller one right here. This one I really think needs to be opened and drained. I've got a wrong picture on here, so I'm just going to cover it. Okay, so we want to inject with lidocaine, then open the abscess. This is an eclipse opening. We don't need to necessarily do that for everything, but what you do want to do is open a small area, press out the pus, drain the pus. You're going to get some blood, actually probably a lot of blood, especially from this one. It looks highly vascularized. And then instruct the patient on care. This abscess is going to be draining for a couple of days, the one that I just showed you. So they want to keep something on that. Okay, this one is a different type of cellulitis called erysipelas. I can't pronounce it. This comes from strep group A. It's going to be a sudden onset, an indurated lesion with clear demarcation. This does, to me, look significantly different than the other cellulitis. So think this is a strep, the other one is a staph. We might need to open this, and we might need to do a CBC if the patient has a fever. For this one, we're going to consider hospitalization as a more likely option, especially if the patient's immunocompromised or if it's in a child. Bite wounds. All right, I'll move it down so you can see. Bite wounds are going to come into your office if you are practicing family medicine. You are going to get a lot of cat-dog bite wounds, and you are also going to get some human wounds. Which one do you think is the dirtiest? I was surprised to know it's actually a human bite wound is the dirtiest, but a cat wound is most likely to be infected. I do not know why that is. Anyway, we're looking at this and saying, this will get infected. We know this will get infected about 90% of the time in cats, and a little less for humans and dogs, although not much less. We want to start this patient on Augmentin 875 for 10 days. Very good. For 10 days, and we want them to follow up with us, definitely. Last one that we're going to do on this group of slides is called Hydrotitis supportive. This is a bacterial infection of the sebaceous gland. It's going to be most commonly in the armpit, the axilla, and it's going to be a Staph aureus, which is, again, the Staph aureus lives on your skin, and it's just waiting to infect you, I feel like. So don't be surprised when you see a lot of staph. Be sure when you're giving antibiotics, you're covering staph if it's a skin infection. It's going to be acute, painful onset with large red nodules and papules under one or both of the axilla that becomes abscessed. You are going to need to drain this abscess and give the patient Augmentin. Tell them to stop with deodorant until this heals, and then to use antibacterial soap, and they should expect scars. Okay, that is 9 down, and only 12 more to go. All right, hope that helped. Bye.